Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. The current series focuses on demystifying the Medical Council standards. And today we're going to talk about getting rid of patients or disenrolling or ceasing the doctor-patient relationship, otherwise known as get out of my consult room and don't come back. We all have patients we'd be happy never to see again. And while it's tempting just to write a letter to say, find another doctor, the situation is not that simple, and getting this one wrong can potentially lead to complaints either to the Medical Council or to the HDC. In addition, GPs have a contractual relationship by virtue of the enrolment process, and proper steps do need to be taken to avoid making ourselves vulnerable. So my name is Tim Cookson, and today I'm joined by Lucy Gibbard and Sam King, my colleagues at MPS.
Hey, Tim.
So let's start by looking at the Medical Council statement and think about some of the principles involved in this process and then work through some examples. So the first really important principle is that you and your staff are entitled to be safe in your work. Health professionals working in ED are probably the most vulnerable to physical and verbal abuse, but psychiatry also has significant risks as well. And in those environments, the option of saying goodbye probably doesn't exist very often, though for the recidivist, the repeat offender, the organisations may need to work out ways to manage an individual safely. But if it's a one-off, that's not able to be done. And so measures such as having security on site or with you when you see a patient may be the best way to protect yourself in those more high-risk areas. In general practice, patients often have the option of other places they can be seen, though with the shortage of GPs at the moment, that's becoming less so. And physical abuse and sometimes even verbal threats can actually result in an immediate cessation of the relationship. But most scenarios are less urgent, and it's here that the principles that the Medical Council has recorded might apply. So the Council states that when you're ending a doctor-patient relationship, you should be fair and professional with the patient and explain the reasons why. And before transferring the patient's care to another doctor, you must be satisfied that the patient does not require urgent medical care. So Sam and Lucy, I think you'll agree this is one of the things that we get lots and lots of inquiries from at MPS, often from practice managers who are tearing their hair out because their doctors have come to them and say, I'm not ever going to see that patient again. You need to do something to get rid of them. But fortunately, I think our practice managers around the country realise that actually it needs to be done properly, and they do contact us, and it's great that they do. 20 years ago, the advice was simple. You just wrote a letter saying the doctor-patient relationship is broken down and cannot be restored, and you'll need to find another GP. There were no warning letters, no explanation of the reason. It was just goodbye. So things are more complex now, and how we go about terminating the doctor-patient relationship actually depends a lot on the individual circumstances, and that's one of the important things. There's no just one blanket letter that you can send out. It really does have to be circumstance-specific. So let's consider one extreme. You've got a patient who's always been a bit argumentative. They swear a bit, but previously it wasn't actually swearing at the staff. It was just use of four-letter words. And they're on long-term opiates for chronic back pain, and these opiates weren't started by you. For a long time, the situation was stable. There was no pressure to increase the dose, and there were no requests for early prescriptions. However, recently, there have been several lost prescriptions. There have been some flare-ups of pain for which he's taken extra doses and which he says then need to be replaced. And one bottle has been lost down the toilet. Now, these are all red flags, obviously, and you realise that limits will need to be applied, and at his next review, you try to discuss the situation. He immediately becomes volatile, swearing at you, yelling in the consult room, and you feel quite threatened. His chronic back pain suddenly does not seem to be limiting him. Your staff hear the noise, and your male nurse comes in to assist. The patient then runs out the door. He shoves your nurse against the wall quite violently, and he yells at the receptionist that he's going to come back and get you all. I think we've all experienced something similar. So, what actions can you take?
Well, that does sound quite extreme, because he's actually physically assaulted your nurse, hasn't he? So in that situation, it may be that you want to call the police, actually, and consider whether you want to lay charges for assault, and also consider whether a trespass notice might be an appropriate way of keeping your staff safe, because I think that's what what you're thinking about is the safety of your staff in these situations.
Yep, absolutely. Anything else, Sam, that you'd like to do as part of this process?
I think you can quite safely disenroll him on the spot.
You don't need a warning letter.
I don't think a warning letter is necessary in this sort of situation.
Good.
And I think it's important for members to understand there are occasions where you can just say no more. And this is certainly one of them. I think we obviously need to think about his prescriptions. And, I work in Auckland, and there are obviously a great number of doctors and after-hours clinics you can go to. And so I don't know that if you're a doctor working in a city that you need to then prescribe a certain amount of medication for the patient to tide him over until he finds another doctor. I think there are clearly other options available to them. But if you were going to be generous, you could do that, ensure that they've got enough supply and before they can find another doctor.
So we're going to write to him, I think, aren't we? Because obviously we're not going to want to come back and have that conversation. So I think at this point we're going to write him a letter and say your behaviour on this date was unacceptable. You pushed a staff member. That is unacceptable. We are no longer able to offer you routine medical services, because you can never contract out of the emergency services. If he comes in having a heart attack, you've still got to deal with that. And then normally we'd say, this is effective immediately, or sometimes we'd say, we'll continue prescribing medication for 2 weeks until you find a new GP. Here's the phone number of our PHO.
I think in this circumstance, you want to make it very clear to him that he's not welcome to cross your threshold again.
Yeah.
So there'll be no physical attendance.
Yep.
And often I would advise the practice that if they think that he may still be angry and still want to turn up and doorstop them, that they should have a plan. All the staff should be well aware that if this happens, then, he needs to be asked to leave the building. If he doesn't, tell him that you will call the police, and then pick up the phone and call the police, and to do that quite promptly. So if all the staff are, have a plan, that means that they won't get into that, freeze position and not know what to do.
And in our experience, the police are actually really prompt generally in this. If they possibly can get there quickly, they certainly will do it, because they do recognise that, having a violent person in a medical practice is not a good scenario to be put up with. Yep. So you're taking all these actions, which is good. How much of this are you going to record in the notes? What are you going to put in the notes about what you've done? How are you going to describe this consult? Do you describe all the details about him shoving your nurse against the wall? Is that health information? Where does this one go?
My advice is usually to put something in the notes to say that there was a consultation, but be very limited in the description about what happened. And but make a more fulsome description and put it into a management file, because it isn't technically health information. It's not going to make any difference to his healthcare moving forward, and therefore it isn't health information per se.
If you're the next doctor who's getting that patient, and there's been no indication that there's been any violence, and the notes don't give any hint that there's been this kind of trouble,
I often would say that you write a factual account of what occurred. I saw Mr. X in a consultation. Mr. X appeared to become angry and used what I consider to be abusive language towards me. My nurse came in, Mr. X pushed my nurse against the door. I think that's all fact, and I don't think, and is it health information? I mean, it may be health information. It's what happened in a clinical consultation. And as I say, I don't think you want to necessarily write every detail of every fact, but I think having an outline of what occurred is appropriate.
Yeah, and certainly a description of someone's behaviour could certainly be regarded as being health information. It's the kind of thing that if you're doing a psychiatric examination, that's an incredibly important part of the documentation.
I think if the patient did have a mental health illness, then yes, it is health information. I would probably err on the side of being, it's not just that you wouldn't document, nothing about the incident. I think we just need to be careful about how much you document, and I would
agree.
certainly limit it, because we've all seen it where doctors have gone into great detail and used every word that the patient used, and which I think is a little inappropriate and not necessary.
And I guess
Not for the clinical notes.
There's a fine line between, if you're thinking about the next doctor who's going to be seeing them, prejudicing that doctor against the patient, and that may be, not terribly fair, versus not providing enough information to give them sufficient warning that they might just need to have their antennae waving when this person turns up, especially if they're going to be talking about things that are challenging, like limiting prescriptions for opiates. So.
I think it would be hard to be criticised if what you've written is factual and entirely correct. I do wonder what the HTC would consider would be appropriate as far as whether or not it would be prejudicing future health interactions. And I've definitely had cases where patients have complained about what a doctor's written in the notes because they have said that's going to prejudice future clinicians who see those notes, and the patient wanted those notes changed. I agree with Sam. It's a fine line. I think you need to write something, maybe just consider. Yeah.
But for example, you might not write that the police had been called, because that's actually not health information, is it? That you called the police. It's information about the actions that you've taken, but that's not his health information.
Yeah. It's tricky.
Yeah, I think we can say it's not crystal clear exactly how much you should write, but I guess the principle here is when you are recording things, just have a think about whether it is actually health information that you're recording, or if it, in fact, no, it really is extraneous stuff that could not be construed as health information, because the Health Information Privacy Code is quite clear that only health information should be entered into the notes. So
I do think it's also very useful to write that detailed account somewhere else, though, because these things often do end up with a complaint. And so even if you've written brief factual account in the notes, you do want that very full account somewhere else. And also for the other staff members involved to have a chance to write their full account in the notes, not in the notes, in your practice system, somewhere secure, obviously, but somewhere where that it is available if there was a complaint in the future.
Good point. So look, a more common situation probably is the same patient, same story, but without the physical violence or the direct threats to harm people. You are sworn at, you do feel threatened, but there's actually no direct threat that's been made. So with the previous response, you both suggested that you'd be doing something immediately, sort of right at that time. How does what you're going to do now differ from those actions that you took last time?
I often talk to practices about how threatened the staff feel, because even verbal abuse can be very threatening for staff. So if the staff feel very threatened, staff can be tearful, need to take a day off work. That's a different level of threat to we're just annoyed because the patient's behaved rudely to us. And I think if it's the patient's being rude, then you do need to take a stepped approach. And I would think the first thing you would want to do is to put some boundaries down with the patient. I'm sure all practices have a policy on acceptable behaviour. towards staff, and you're quite entitled to apply that policy.
And I think actually a common problem that we see is that often the patients have been rude or inappropriate in the language they use towards staff. Often it's not the doctor, it's often other staff.
Yes.
But often nothing has happened for quite a few occasions, that actually the behaviour has been repetitive and all the staff know that Mr. X has behaved that way and is likely to behave that way again, but nothing is done for quite a long time. And then often something happens and all of a sudden people want to do something, but actually you should actually early on, when a patient is behaving inappropriately, that should be flagged and there should be an action taken. I'm not saying that you ask them to leave your practice, but there should be some boundary setting there.
Yep. Yeah. But you're absolutely right. We do tend to let those things drift a wee bit and think, they're pretty stressed at the moment. Families situation's pretty awful, and you keep on making all these excuses and allowances, and then, as you say, finally something happens that you're just no longer prepared to do that. But it does leave you kind of well behind the 8 ball in terms of taking action, because they can say, well, look, I've been using the same language to you for the last 6 months. Why are you suddenly taking notice of it now? So, if you can get onto it early, it certainly is important. Is this going to be just a conversation you're going to have, or are you going to write to the patient?
I think it really helps to have something in writing. I think you can have it as a conversation, and often it really depends on your relationship with the patient and what you feel comfortable with and what's going to actually create the best outcome. But sometimes it may be a conversation where you hand over a letter, but there are situations where you're going to email or send a letter, and the sooner after the incident that you do that, the better. You don't want to leave it 6 weeks or a couple of months. If you can, within a day or two, actually write an email saying, this behaviour on this day was inappropriate because of this. It upset our staff. Our staff have a right to a safe environment free from abuse, if this were to happen again. So you're going to lay it all out, exactly what happened, why it was inappropriate, and tell them the consequences if it were to continue again.
I think you've made a good point about being specific about the time and date and exactly the behaviour that they find questionable. And the practice managers, I think it's a good thing for them to keep it documented for every incident, because often by the time it comes, they come to us and say, we want to get rid of this patient. They don't have those times and dates. They can just give you a vague, the patient's behaved badly, and they swear at us. And it's very difficult for anyone, i.e. the patient, to be able to respond to that. If they say, well, when did it happen? I don't remember doing that. And you've got no evidence per se.
And the other issue is the thing that often generates the practice wanting to do something is when the patient complains, and the patient is often unhappy, and that's why they're shouting and being difficult. And then they make a complaint, and that's when the practice say, well, actually, we don't have to put up with this anymore. But actually, the Code of Rights, Right 10, is the right to complain, and you can't really. The practices are on a complete back foot at that point if you're trying to establish boundaries and behaviour at a time when the patient has just put a complaint in, because it can look like that you're imposing those boundaries because of the complaint, and you're not allowed to do that. So actually it's much better to do it before there's a complaint, and actually don't wait for the crisis, and actually try and establish those boundaries early on.
Mm-hmm. And certainly taking into account each individual circumstances is important as well, isn't it? Because particularly if there are mental health issues which may decrease someone's ability to moderate their behaviour, I think the HTC would expect us to take that into account with whatever actions we take. So we've got to be fairly careful in those circumstances that we do actually consider all of those things, balancing that against keeping up staff safe, and sometimes there's a real tension there between those two requirements. What about suggesting a meeting to agree on acceptable behaviour and that sort of thing? Have any of you had experience of whether that strategy actually works?
I think it's a very useful thing if you are happy to proceed with a meeting. I think it depends on the nature of the relationship, how tenuous it has become, how difficult the patient is to confront. What you don't want is to go into a meeting for the staff to be further intimidated. So I think it depends on the situation and the people involved. But it's always helpful, I think, if you can have a meeting and follow it up with a letter, or give them a letter and then meet with them to discuss the letter. And then you can finalise whatever moving forward.
I've certainly had the odd experience where the practice has said, look, we'd like to have a face-to-face meeting to discuss behaviour and what is acceptable behaviour. And I think that's probably quite kind of intimidating for patients, to the thought of coming into a meeting like that. And that on at least one or two occasions has been enough, it seems, to be the precipitant for the patient to then make the decision, I'm going to go elsewhere. And of course, the practice is not going to stop them from doing that. So, even if, and conversely, I've had a couple of occasions that I can think of where actually the meeting went really well, and patients generally just didn't appreciate the impact of their language, and getting that sort of shot across the bows actually worked. And so you can end up, I guess, with sort of three possible outcomes, really. One where patients actually accept that, yes, what I was doing wasn't appropriate. I'm happy to curtail that and behave accordingly. Others who leave because they don't like to be challenged, and that, of course, is an outcome that is fine for that practice, not so good for the next one, but fine for your practice. And then there are others who ignore everything that has gone on, ignore your letter, ignore your discussions about what's acceptable and not acceptable, and the next contact they have, it's exactly the same. So what do you do if the warning is ignored and the behaviour continues?
Well, if you've given them a written warning, that is very helpful at this point, because if you've actually said, this is the behaviour that is unacceptable, this is why it's unacceptable, and these are the consequences if it happens again, and generally the consequences would be, we would ask you to find another practice, or we would ask you not to come here anymore. Then if it happens again, you're actually on pretty firm ground as far as saying, look, we explained to you that behaviour wasn't acceptable. On this day, this happened again. Once again, our staff were very upset. We can't continue like this. You actually have to find another doctor. And in those situations, again, you've got the issue of how a time period for them to find a new doctor, and also the issue of how do they find a new doctor. And we often put the PHO phone number on there to try and help the patient find a new doctor, because there is some, if it's not an urgent situation where there's been a very serious acute situation, there is that responsibility to find alternative care, or to at least help the patient become aware of sources of alternative care.
I think if you offer to help them to find another practice, what you don't want is for them to be held over a barrel when they say, no, I'm not going there, you have to find me another doctor. And so I think it's important for practices to understand you don't have to do that. You can certainly help them or offer them that these practices still have their books open, you could try here, but not to obligate yourself to do that.
I think showing them how they can find care rather than actually find it for them. But the problem, and it's becoming an ever greater problem, is where actually the practice is in an area where no local practices have their books open. And so then the patient can quite rightly say, there is no alternative care. How am I going to have care without you? Because I can't get into any other practice. And that's tricky.
But of course, they're then in no different position from the other people who are on waiting lists wanting to get a doctor as well. So they're no worse off than some of the population, but they're worse off than they were before. Their behaviour created the situation that...
In that situation, you would hope that the patient might be able to modify their behaviour if they want to have healthcare provided. But I don't think a practice is obliged to keep a patient on if the patient is behaving so badly that the staff are intimidated.
So if you are telling them that they need to find a new GP, how long do you give them for that before you cease providing any services, such as, if there's an emergency or
If you're in
for a
Auckland?
repeat prescription?
In Auckland, I would say 2 weeks. If you were in a small centre, maybe 4 weeks, or depending on the situation.
Yeah, and I couldn't find anything in the council guidance as to the kind of timing for that.
Yeah, I don't. I think it's the. I think the other issue is you're always obliged to provide emergency care. So even if the time period has passed and they're no longer actually enrolled with you, if they turn up on the doorstep in need of urgent care, you can't refuse urgent care.
Though if it's the patient you've trespassed from our earlier case, that's a little more tricky, isn't it?
To provide
I think we have an
urgent
obligation
care- I
to
think
help
you
in an
have- yeah,
emergency.
for
You
an
have
emergency.
to. Unless there's another doctor available to help them in that situation, you're really pretty much dealing with it.
But I guess if you're genuinely worried that this person could be, not only does they require urgent care, but they're still physically capable of causing harm, and you might call the police in that situation and say, look, we're going to be providing this chap emergency care because he needs it, but actually, would you mind coming around just to make sure that everyone's safe?
I did have one case where the patient decided that all their care was urgent. And so they'd,
Yes.
they'd come to the front desk and say, I'm in need of emergency care. And in the end, we wrote a letter saying, urgent care as judged by the triage nurse, rather than, because otherwise there was a loophole that the patient was using to continue to have routine care.
Okay, so look, that's one scenario with the significant behavioural issues that our patients exhibit. But there are other patients, aren't there? And they're the ones that you just can't get along with. And in the end, they create that increasing feeling of dread. Every time you see their name on your appointment list, you think, oh, God, what are they going to come in with today? And I don't know how I'm going to manage it. They tend to consult frequently, so their names crop up often on your list. And these are the patients, too, that often send you lots of emails and texts in between consultations. And eventually you realise that actually you're not able to offer that person good care because of your emotional response to them. You're just not looking at them from an unbiased point of view. So it is actually no longer appropriate for you to provide that care. So can you just sack them, or is it a bit more complicated than that?
That's a very tricky question there, Tim. My advice to members where they've got these difficult patients who are constantly calling, emailing, etc., is to put some firm boundaries down. If patients are taking 45 minutes instead of 15 minutes, then I think the practice are entitled to charge them for that time, make sure that they book a double appointment and charge them appropriately every time. That they don't get consult by email. If that's not, if they're taking up a lot of time in phone calls, I'd put boundaries around those and appropriately charge when you can. And often those things can be enough to change the behaviour or for the patient to move on because they're not getting that free service that they were getting before. I think that it's very difficult if you can establish that the patient no longer trusts you, because often with these patients, it can be an issue of trust. They're constantly coming, it didn't work, and you're not doing this for me, and I want that, and there are low grade but continual complaints. Then you can raise the issue of trust, because if the patient says, "Well, actually, you're right, I don't trust you," then I think you do have grounds to break the therapeutic relationship. I think if that's not the case, I think it's actually very difficult to ask the patient to move on unless you've got a good alternative that is acceptable to the patient.
Yeah, and I think that often these patients that engender that feeling in you of inadequacy and stress, and that you can feel your blood pressure going up before they walk in, then often there are personality issues there. And actually, it really helps to take a step back and actually look at how you're reacting to them. And I totally agree that putting in some boundaries is really necessary, but I often find that the boundaries are necessary for the doctor as well as the patient, that actually you find the doctor is giving 45-minute appointments and is answering these 5-page emails, and the patient who sends you 17 journal articles that they want you to read before their 15-minute appointment tomorrow, and we all have them. And you have to say, no, there is no time allocated for me to read these journal articles, and unfortunately I've been unable to do this within, you've got a 15-minute appointment, I'm happy to discuss your concerns then. The problem is then the doctor needs to not then read them all, and, that you've got to stick to your own boundaries.
So it's a bit like children, really.
Oh, it's hard. It's very hard. But I think... And often I actually think I think it is hard to ask them to leave, but sometimes you have to. And actually it is something that the doctor's getting burnt out, and they're actually not going to be able to look after all their other patients because of this one patient that is causing them so much distress. And I think it will be interesting to see what would happen with the HDC if that sort of patient complained about being asked to leave, because I think that the doctor could... I'm thinking of a particular case where I was assisting a member where the doctor genuinely felt that they couldn't carry on providing care for all their other patients because of the distress that this one particular patient was causing them. And I kind of think, well, then actually you have to ask them to leave. Yes, there might be a complaint. I don't know how the HDC would see it, but actually I think it's not actually really a choice at that point if that doctor was going to have to give up practice.
Well, it's not in the patient's best interests if the doctor is unable to provide them with the usual standard of care.
Mm.
And you do see doctors who do get burnt out and very stressed. And I think that in those situations, it's important to explain to the patient how stressed the doctor is, and the distress that it's caused and the impact on them, so that the patient at least has some understanding.
And this is also a situation where you'd hope to have understanding colleagues at your practice, because clearly if you can offer someone else within the practice to look after them, and sometimes these patients need to spend about 3 years maybe with each GP, and that's about as long as any one individual can put up with them. And that then still allows you to fulfill your contract with the enrolment to the practice, but escape the trauma that is becoming worse and worse every time you see their name. Mm.
And there are plenty of patients who you may not click with, who might gel with your colleague next door, and they get on fine. Yeah, it's a very individual thing, isn't it?
Yeah. And it may be just that, as you alluded to, Lucy, you might be going through a slightly bad phase, and this is someone that, normally you could put up with, but actually for the foreseeable future, you're not in a personal space to be able to do that. And taking steps to protect yourself is certainly important. So we've talked mostly about general practice here. Is it any different for a private specialist practice or a hospital practice? I guess in both of those circumstances, it's more likely that the care is going to be episodic or time limited, and therefore the same difficulties are less likely to arise with that person who just chronically gets to. And maybe in the hospital there'll be another colleague who can take over the care. But if you're in private and you're seeing someone long term and would be continuing to see them, then the same principles I would think apply as for a GP. Though it's interesting, I can't recall. Oh, no, I've had one or two specialists, but mostly not so much because they really couldn't get on with the patient anymore, but because it was all the letter writing and those other things that were really driving them mad, and needed guidance on how to set those limits that you were talking about, Lucy.
I think the paediatricians sometimes have these issues, actually. I've done some cases with some paediatricians where they've really struggled.
One of the difficulties for the hospital doctors is if there's no one else within that specialty that they can refer to, and so there's nowhere else for the patient to go. That, I think, is a difficulty.
And the other difficulty is when children are involved. I was just thinking, taking that on from the paediatricians, if it's the parental behaviour that is causing the problem, and actually the child still needs care, that's kind of difficult as well, because it may be that you actually, it's not the child per se who's the patient that is causing the problem, but it's the parent.
So it might be easier, though, perhaps for those clinicians to have someone else with them during the consultations to at least kind of dilute some of the behavioural impacts and help keep things on track a bit more. So having a nurse with you, or if you're a hospital specialist, having a registrar, house surgeon, just for moral support to lessen that emotional impact.
I think it's slightly easier if you're in secondary care. If you reach the end of the therapeutic road, in other words, you're not really able to offer the patient any more, then it's reasonable to discharge back to the GP. And that's how you end the therapeutic relationship. Primary care, of course, it's different, where they're enrolled with you, so you have an ongoing duty of care.
And what about that scenario where you've had that patient that you had the difficulties with, you never actually got to the point of addressing the issue directly, but they take the right route, you think, and decide to leave and go to another doctor. But 3 months later, they knock on your door again and say, I want to become your patient, and you happen to be taking on new patients at the time. Do you have any responsibility to them?
I think it depends how bad the situation had got before they left, really. And I'd often talk to the doctor about the pros and cons of the two ways of dealing with it. One is to say, I believe there'd been a breakdown in our relationship, and that actually it wouldn't be appropriate for you to come back because I don't think I'm going to be able to offer you the care that you need. Accepting that if you say that, the patient may complain, and that's entirely possible. I think in a lot of these situations, the GPs would rather have that and deal with that complaint than actually have to carry on dealing with the patient. So that's an option. Or the other option is to say, yes, you can come back, here are the boundaries, And so you set some really firm boundaries at the very beginning. And then again, if the boundaries are breached, then you can say, look, actually, this hasn't worked out. You're going to have to find another doctor. So, yeah, I think in a lot of situations, the doctors would rather say, no, I'm not going to have that patient back. It was too distressing, and I think it would be detrimental to me, and also not good for the patient, for me as their doctor, that actually I'm unable to provide them with the care that they need. Therefore, I'm going to say no, and then if they make a complaint that I've discriminated against them, then
I think that if they did make a complaint, the HDC would be understanding if you can explain the reasons for not wanting the patient back.
I think it depends on whether there's an opportunity for the patient to have care somewhere else. And I think that's more and more going to be our issue, does the patient have an avenue to receive care?
Ultimately, I think that the hospitals have the responsibility, because the GPs that are contracted ultimately to the hospitals to provide the care. And I have seen it where the hospitals have had to take over that responsibility, where the patient has burned their bridges with all the practices in the area. I don't think it happens very commonly at all, but ultimately it becomes the responsibility for the hospital.
And certainly for the GP, I think there's no legal requirement to take the patient back on again, so you can't be forced to do it. They're no longer enrolled, so you no longer have that responsibility. The risk would be of being perceived as being discriminatory because you didn't take them on. But in fact, if you've got specific reasons why you're not taking on that particular patient because of your prior knowledge, then actually it's no longer discriminatory because it's based on prior knowledge rather than assumptions or preconceived ideas. So that would be the defence if a complaint went that I'm being discriminated against. But hopefully they don't. So thank you. In summary, it's just a useful reminder to know that actually ending a doctor-patient relationship can be tricky. And if it's not done properly, it can leave you vulnerable to a complaint to the medical council or to the HDC. As we've said, it's one of the commoner queries that we get, and we're happy to give advice. And certainly many of our colleagues choose to contact us for that. Thoughts to finish off the lessons.
Read the medical council statement. I always think it's always good to know what the rules are. The medical council statement is actually on their website. It's not very long. It's reasonably easy to read. If you're thinking about asking a patient to leave your practice, do ring us, but read the statement as well. It's got some good advice in it.
And at the end of it, the good advice is if you're considering ending a doctor-patient relationship, consider contacting your indemnity provider.
So there's a circle to go around.
Colleagues. So that's definitely the message. Thank you, Sam. Thank you, Lucy.
Thanks, Tim.
Thank you, Tim.
And thank you too for listening to this podcast, which I hope has been helpful for you. We look forward to catching up with you in our next podcast. And if you like these medical protection podcasts, please subscribe and leave us a review. If you'd like a podcast on a specific topic, we'd be really pleased to hear from you. So please email us at nzpodcasts@medicalprotection.org.